Welcome back, everyone, to our next session of eSpace CRM on anti-obesity medications clinical experience. I'm Mark Cornier. I'm a professor and director of endocrinology at the Medical University of South Carolina in Charleston, South Carolina, and I'm the current president of the Obesity Society. It's a pleasure to be joined today by my co-chair, Dr. Wei-Ling Lau, who's a nephrologist at the University of California, Irvine, and by our presenters. So we have Dr. Peter Rossing from Steno Diabetes Center, Copenhagen in Denmark, presenting the nephrologist's view. Dr. Scott Isaac from Atlanta Endocrine Associates in the US, presenting the diabetologist's view. Dr. Jevett Butler from the University of Mississippi Medical Center in the US, presenting the cardiologist's view. And then finally, Dr. Stefan Anker from Charité Campus Virchow Klinikum in Germany, presenting muscle wasting associated with AOMs. After all our presentations, we will conclude with a panel discussion and Q&A, so please be sure to stay tuned and ask your questions. I'd now like to pass over to Dr. Peter Rossing for our first presentation. Thank you.
Hello, my name is Peter Rossing. I'm professor at Steno Diabetes Center in University of Copenhagen, and thanks for giving me the opportunity to talk here about anti-obesity medications and the clinical experience from a nephrology perspective. These are my disclosures, and this is particularly relevant because recently we had a conference organized by KDIGO looking at obesity and kidney disease, pathophysiology and management in Prague last fall. Also, recently, the American Society of Nephrology issued new guidelines on how to manage obesity in people living with kidney disease. And unfortunately, as you know, obesity is an increasing problem. Approximately 50% are obese and 25% are morbidly obese, and that goes across all the world and particularly here, as you can see, also in the US. With increasing obesity, there has been an increase in chronic kidney disease. Now, more than 800 million people are expected to have chronic kidney disease around the world. It's increasing as a cause of death. And there's a big overlap between cardiovascular disease, kidney disease, diabetes, and obesity. With obesity both having a direct link to kidney disease, but also causing diabetes and hypertension and other conditions leading to chronic kidney disease. And all data here linking obesity to the risk of kidney failure and obesity, just to highlight that indeed there are good data also from many other studies linking obesity to risk for kidney failure as here, but also as fast decline kidney function or the presence of chronic kidney disease. This can be, as I said, either directly that obesity leads to production of adipokines affecting the kidney, such as the podocytes, and causing direct obesity-related chronic kidney disease, but probably most commonly through diabetes and hypertension with excess risk of chronic kidney disease and eventually kidney failure. So this with obesity and kidney disease is becoming an increasing problem, but fortunately we are having increasingly good opportunities of managing obesity in general and also in kidney disease and in diabetes. These are recent data from trials with semaglutide 2.4 milligrams showing weight loss up to 10% in diabetes and even more in people without diabetes, and with tirzepatide, the GLP-1 GIP agonist, also showing marvelous effects on obesity, here 13% in diabetes, and even more is seen in people without diabetes. In the guidelines for managing chronic kidney disease and diabetes, we have GLP-1 receptor agonists here in the pyramid of KDIGO. Now, GLP-1 receptor agonists are recommended not because of the obesity effect, not because of the kidney protective effect, but because of the cardiovascular benefits seen with GLP-1 receptor agonists and because they are good glucose-lowering agents but these guidelines were made before we have flow data that I'm going to show, because there was reason to believe, based on cardiovascular outcome trials, that there could be benefits on the kidney as well as on the heart. Here are from cardiovascular outcome trials in type 2 diabetes data showing less progression of kidney disease with GLP-1 receptor agonist, particularly if you include albuminuria progression as in the top, whereas it was less clear if you excluded progression of albuminuria in the endpoint. That was in the cardiovascular outcome trials. If you look into those using semaglutide and liraglutide, LEADER and SUSTAIN 6, and focus on those with GFR 30 to 60, so impaired kidney function and increased albuminuria, there is a progression not only or preservation of kidney function, so less reduction in eGFR, 30 to 57% reduction in kidney function is reduced with this incretin-based therapy that is also useful to treat obesity, as I mentioned before. To really test this in type 2 diabetes and kidney disease, the FLOW trial was conducted. Now, I should say this was not the obesity dose of semaglutide. It was 1 milligram, and it was also not a requirement to be obese, but the mean BMI was around 30 in this population of 3,500 patients with type 2 diabetes and kidney disease. The trial demonstrated a benefit on progression of kidney disease, so a 24% reduction in progression of kidney disease and cardiovascular and kidney mortality. And this was both significant for kidney disease progression and for cardiovascular outcomes and mortality. So here you can see the summary of the FLOW trial. So incretins that we use to treat diabetes and also to treat obesity can reduce kidney progression, major adverse cardiovascular events, and mortality with 18 to 24%. And also, if you are an SGLT2 inhibitor, this is working as well, as shown in this SMART-C analysis. SGLT2 inhibitors work with or without GLP-1 receptor agonist. And if you look in obese patients, here from the SELECT trial that studied semaglutide in people with obesity and a history of cardiovascular disease, there was also less progression of kidney disease, particularly because of less progression of albuminuria, but also because of a slower decline in eGFR. And in non-diabetic kidney disease, also we got this kidney study called with semaglutide, showing a benefit of reduction in albuminuria. It was a short-term study. It's a small study, but showing that GLP-1 receptor agonists reduce albuminuria in non-diabetic kidney disease and obesity. And as I mentioned, there are also other anti-obesity drugs like tirzepatide, the GLP-1 receptor agonist. And based on the SURPASS-4 trial of tirzepatide, there was also a benefit on progression of kidney disease. It was a secondary endpoint, but still, again, promising for the anti-obesity medications for kidney protection. So I'll conclude that obesity is increasing dramatically, is associated with chronic kidney disease. Interventions that reduce weight reduce chronic kidney disease, and effects of weight loss. We should be aware of creatinine and consider using cystatin C, particularly with large weight losses. And then incretin-based therapy reduce weight and progression of chronic kidney disease, and models of care are important when we want to implement this in our clinical settings. So with this, thank you very much. I look forward to our discussion.
Hello, my name is Dr. Scott Isaacs, and I am from Emory University in Atlanta, Georgia, and I am the president of the American Association of Clinical Endocrinology, and I'm pleased to present to you the diabetologist and endocrinologist view of anti-obesity medications and the clinical experience.